and he is the course coordinator of the TCT India and South Asia. I just recently finished. And he is the director of clinical cardiology as well as the research activity of Apollo Hospital, Apollo Health City. Dr. Srinivasan, please.
Good evening, sir. Thanks for the opportunity, Dr. Mantosh Panja, sir. We appreciate your interest and all your efforts. Even at this age, you are very active as more of the young cardiologists. Lot of good faculty, lot of learning going on. I wish my slot also would have been taken by Dr. Hiramat, sir. He was showing some excellent cases, and I really like the way he projects and puts cartoons to explain. That's a passion of teaching. And I love to see Ferenc again and enjoyed the talk of Dr. Shal. Good evening, Ferenc, sir. So what Dr. Panja wanted me to talk was basically to repeat the talk which he liked in that previous conference which you mentioned. So I'll briefly present our approach to this multi-vessel PCI. I wish we could have more cartoons and interesting slides like Dr. Hiramat, but excuse me, we can't. Everybody cannot be Dr. Hiramat. But I will basically try to give the approach how to decide in dealing with multi-vessel PCIs. Good best wishes from Apollo Group of Hospitals. And when you see the types of cases which are done, the main institute where probably more and more of complex cases come, and then hub and spoke model, all the peripheries, more of a single vessel disease is being done. The same thing gets reflected. I think Ferenc said in their institute, 70% are the multi-vessels. It depends upon the setup in which you're working. So what I would thought is mention briefly what is the status of this PCIs in our country, what we collected in NIC, and tell you briefly the steps of decision-making process on how to utilize FFR, sometimes if QFR is available to you, and show some case examples. And the time is only 10 minutes. I would skip some of the cases which are shown and be very brief. Initially, this was strict compartments like this. Most of these multi-vessels left main go for CFBG, and the PCIs we were doing only for single vessel disease. But now with better quality stents and advent of imaging and increasing expertise of operators, there's nothing left actually which is not there suitable for PCI. Only thing is we need to have appropriate expertise, and everybody seeing Dr. Hiramat's cases should not plan cases like that. So it is initially in the early parts, then most of the single vessel diseases only we were doing PCIs, and multi-vessel for going for CABG. Now in the 2020, it is reverse. 80% of the work PCIs come from multi-vessels come for PCI. And the same thing, we could collect the NIC data. I'm happy that the country, Dr. Ferenc, I think it will be happy to note about significant number of cases are done. 438,351 PCIs out of which, and about 1/4 of them are multi-vessel PCIs, and 2.3% were the left mains. So coming to the decision-making process of the basically multi-vessel PCIs, we need not go by single vessel, double vessel, triple vessel. Many of the times in peripheries, it happens that even small branches will be considered as another vessel, and patients are being sent for surgery. So we need to understand the decision-making process, and probably whenever LED involvement is not there at all, then there's no point sending these patients for surgery, whatever the disease, other lesions may be. That can be the broad guideline and rule. And where the location of lesion also becomes important, where vessel is proximal, mid, and distal. Somewhere distal branches, you need not consider it as another vessel disease. And lesion significance becomes most important. As we see many of the times, lesions which are mild, moderate, when FFR is negative, many of these multi-vessels could become like single vessel. And what is other most important process which you need to consider is symptom status, whether it's presenting with acute ACS type of scenario or chronic stable angina, and what is the LV function in these patients, because we need to plan the procedure appropriately if the patient has a severe LV dysfunction. So these are the major issues when you are planning for multi-vessel PCI. When you are planning to do multi-vessel PCI, we should have a complete revascularization, and we should get the optimal results because we are trying to compete with our surgical colleagues. So complete revascularization, do we mean that every small branch we need to chase and do anatomically complete revascularization? Not so. Functionally complete, and especially when the significant vessels, all to be revascularized. And if sometimes in acute scenarios, we might do only culprit vessels, and the rest of it, such sort of lesions, small multifocal lesions which were there before, now nobody sends for surgery because they're all focal lesions, and all can be tackled with multi-vessel PCI, especially when the stents becoming less. But when you are having long lesions, tough lesions also, we have now contemporary data in the various these trials which are shown here that PCI can be offered safely in all these patients of multivessel PCI also, but provided you need to take care of the safety and you have equally good results like surgery. To do this, then sometimes it becomes calcified lesions, long lesions. It becomes very important to have optimal stent expansions and do the procedures right and avoid procedural MIs by following the protocols well. And previously, the length of the stents were a concern. Whenever we were students more than 30, we used to think that restenosis rates would be high. Now the length has become less and less because now with the advent of drug-eluting stents, probably when the lesion length class 60, then only we think of having restenosis. This again becomes important not to have a branch loss and preserve all the branches, not to get into periprocedural MIs because sometimes patients could have trouble post-procedure. The sort of stent incomplete expansions again should be avoided by proper bed preparation and then using various types of cutting balloons or high pressure balloons to prepare. The surgeons also had a lot of advantages. They claim arterial conduits, op-cap, and robotic surgeries. And we need to see what is the outcomes that's happening and whether we're equally able to compete with them. What is the most problematic for the surgeons is the graft occlusions, which often happen. About 40% of grafts tend to occlude, but the strength of the surgery is lima, which tends to remain patent. So if you see, this is the important decision-making flowchart. For the sake of younger cardiologists, I would like to take 1 or 2 minutes to explain this. If a patient has a three-vessel disease, and then probably you assess the syntax score, Euro score, whether it's high risk for surgery or low risk for surgery. If patient is low risk for surgery and he doesn't have any contraindications and is not averse for surgery, still it is okay. But if a patient has the ACS or acute MI type of situation, it's not easy to do a surgery in this types of scenario. So probably you could decide for a staged procedure with doing a culprit vessel PCI now and evaluate other lesions and do a staged procedure. But finally, we should have a complete revascularization. But the patient's clinical status again has some of the comorbid pathologies like CKD and other things. Again, proper planning of it helps. And if patient has CTOs, I think this is where some people keeps asking questions in today's scenario, which are the patients you're sending for surgery. If there are more than two CTOs in a patient, probably that is one patient with which we might tend to send for surgery. Left mains now I think is conquered. That is not an issue. But more than two CTOs in significant long vessels, I think those are the patients who go for surgery, and some diffuse disease and where total revascularization is not possible with stenting. So that is another subset should go. So this is stable patient, then probably you can plan the procedure. But what I would like to mention again to youngsters, whenever the patient has acute MI, ACS type of scenario, try to avoid surgeries in the acute stage and try to do a culprit vessel PCA procedure and try to do a revascularization total later. I think this I amply stressed upon the importance of assessing the overall clinical status and treating ACS and acute MIs and with a higher priority to do the best to immediate revascularization. Some of these case examples, which we did live transmission before, and then the recent another TCT conference, I thought this is a good case because where we compared QFR with FFR, and I don't go into clinical details, but basically this is a borderline lesion I thought in the LCX. Then there is a LAD, again has a tight disease. One of the vessel anyway had tight disease that we revascularized immediately. And we wanted to show the LAD was not a very great lesion. It revascularized stents. And then that is a good result. Then we went on to LCX. I thought it is not much important here, and some of the panelists felt it is important. The QFR, this is another modality which is coming up. I think now it is being marketed in the country also. And basically, you need to take two angiographic views by 25 degrees apart and calculate the values. Totally, you get the QFR values online. It takes about 3 to 5 minutes. Everything we showed while doing a live case, and we get uh, values. This can be done even with a diagnostic catheter. That is the advantage. You get values like this. Other advantage of this is you scroll the bar here, and suppose you have multiple lesions, you can get QFR values at that particular point. So basically, there are studies comparing with this IFR, FFR. Here, if what we got in this LCX was 0.82, it is again thought to be borderline. Then we also did FFR value with a wire. Drift was also tested. It came not important and we left it. Then the same sitting RCA was having this another lesion here. Patient probably had a ACS type of scenarios, or cardiologist who referred felt that he had some inferior wall changes. So that is how RCA could have been thought as important. In some views, it was looking important. Then, but we did a QFR. The other advantage, just to show it, is when we were trying to do FFR with adenosine, patient had bradycardia and troubles. The QFR came 0.8, and that's how the FFR value again was checked with intravenous adenosine. It came 0.78, and then this was tackled, and the result was good. So that's clearly demonstrated the importance of FFR. And then probably if you have facility of QFR, about 50-60% of cases of FFR we could avoid doing by QFR technology, and then still take a help of wire FFR in ambiguous situations. That was a good result finally, and patient is doing fine on follow-up. Then another interesting case, sometimes this is a chronic stable type of case in elderly, now simulating patterns like West, 92-year-old gentleman having a recurrent angina. He had calcific disease, and he also had a recent TIA and surgery. Patient was not willing for surgery, and surgeons were also not willing for it. And if you see, I would rush through because see diffuse disease, calcific disease, and LCX disease, LAD disease, and then the RCA was also deceased. Such sort of things, then you have to properly discuss with the patient, and the frailty, TIA, keeping all that. For the sake of time, we're skipping with better quality of stents and probably better expansion. Then LCX was revascularized. Then later LAD was revascularized, and RCA was also done. Another patient is acute scenarios with, I think I have 2 more minutes, acute scenarios with triple vessel disease, LV dysfunction. This patient had a recent problem. Probably if you see that LCX is occluded here. And then we thought the LAD disease, initially we thought it may not be important, but the proximal vessel lesion was looking important. But again, there's a second level of disease here. So our plan was, if LAD comes important, probably he could still send the patient for surgery to discuss with him. But in this, that was RCA, which was again occluded. So we thought we'd do FFR to LAD, and if it comes positive, we'll discuss regarding surgery. If it again still he doesn't want, then we'll go proceed with multivessel PCI. If you see here, some of these RCA is also feeling retrograde. This is a FFR wire. This is again demonstrates the more proximal the lesion in the FFR in the vessel, and the more the area of supply, it tends to come positive. Then FFR came significant here in the proximal vessel. Then patient also became little had pain, and adenosine became 0.67. So though we wanted to do LCX first if you are doing, but we were forced to do LAD immediately. And then after that, we had again worked up for this is a proximal LAD was stented. That was not a problem. Then again, we were wanting to check the LCX. We crossed it with the Fielder XT type of wire. And because of recent occlusion, we could cross it. And then longer stents were used. And then probably that's the result of LCX, which came out well. Then RCA, we went on to do RCA. And again, same Fielder XT was used with balloon support. We could cross. And then after we opened, then there was one more distal lesion. These are all like expected things. Then counseling prior for the financial issue shouldn't be there for us when you're doing such tackling complex cases, and we should not have problems on table of finances. Then we had to use another extra stent there. That is the final result we got for RCA. And finally, when we checked post RCA, then distal vessel of LAD came negative. Here after this, then we left the distal lesion. What we thought is that the area when it was perfusing the RCA, it came positive, but later on when RCA was opened, then probably this is negative. These are things to be seen further, and FFR values also depend upon the perfusion areas which these vessels supply. That is what I think a message what we learned from this. I just wanted to present this again and share opinions from all. So this is what initially pre-FFR LAD baseline was. This came positive. We stented this. Then distal LAD initially was borderline. Then after we did RCA stenting, it came negative. So distal lesion was not stented. So in this era of multivessel PCI, we want to do complete revascularizations and probably do a good job, minimize myocardial injury, and have good results of expanded stent. And we need to do all this because we don't want our patients to suffer in ICUs like this. We want our patients to enjoy next day and if not next to the next day, especially in the radial era, it's become more comfortable to the patients. With increasing expertise and better quality stents, now PCIs will increase, CABG will go down further, but probably hybrid revascularization with where Lima is very strong with LAD and probably DES to other vessels could be the solution, provided we come up with some hybrid cath labs, and the cost also should be considered and come up with the packages which could be best. And probably acute MIs and ACS scenarios, we still have a lot of importance to PCI, and primary PCI will remain to stay, and it is difficult for surgeons to organize everything in acute stages. So I feel in the acute MI, ACS scenario, still PCI dominates. Only in the chronic stage where you have LAD involvement, there is some role for surgery. When you ask patients, patients always want the less invasive PCI procedures, but we need to have a proper discussion with them, heart team approach, and then try to do what is best for the patients. And then whenever the syntax score is less than 32, you have no issues now. If it's more than 33, also many of us tend to do procedures, PCI. We need to keep the important patient's outcomes in view and do image guidance and do optimal results, because we're competing with surgeons and you do trying to do a good job. What we need to understand is if immediate result is good, then only the follow-up results all for the patients also will be good. And but again, if your intentions are to do good to the patients, and always things will fall in place, and God will help us all too. Thank you very much for patient hearing.
Thank you, Srinivasan. The excellent presentation on excellent cases. Please stay, we'll discuss at the end. In the meantime, can I call upon Dr. Shiv Kumar, and he will present the tortuous RCA, how to manage. Dr. Shiv Kumar, the senior dynamic intervention cardiologist, and particularly intervention he is on the top in the intervention cardiology in case of Madurai. And he is working now at present in the Meenakshi Hospital and Research Center, Madurai. Dr. Shiv Kumar, please.